Hello. This next presentation in PT 549 will cover infectious diseases. This slide describes the required readings for this presentation from Goodman and Saccone. Please take a moment to review the learning objectives for this presentation. Let's begin by just speaking about the influences of infectious diseases over time. If we look back about 120 years ago, infectious diseases were a leading cause of death in this country. Today, infectious diseases are still a significant cause of morbidity and mortality. However, they've been far surpassed by other causes of death, including heart disease, cancer, chronic respiratory disease, and stroke. And as the influence of infectious diseases has decreased, life expectancy has increased. And if we look at why life expectancy has increased and infectious disease influence has decreased, we see really several reasons, and we look at less overcrowding for our living conditions, better hygiene standards, more frequent controls of disease outbreaks, mostly due to public health policy with respect to sanitation, hospitalization, and pest control. In addition to what we described previously, vaccinations have also played a key role in decreasing the influence of infectious diseases in this country. This slide provides definitions for three important terms for this particular presentation: infection, colonization, and infectious disease. Take a moment and familiarize yourself with these definitions before moving forward. This slide provides two additional definitions related to pathogen and virulence. Once again, familiarize yourself with these two definitions before moving forward in the presentation. Let's take a moment and describe the functions of some of our cells of natural immunity. The first is a macrophage, and a macrophage is a white blood cell that plays a very important role in our immunity. First, it recruits lymphocytes, which is our body's main immune cell. It also engulfs foreign particles, bacteria, and pathogens. Next are neutrophils, and neutrophils are our most common white blood cell, and this is looked upon as really a first responder to disease. It has a couple of important functions. Mostly, though, it releases cytokines, which are signaling cells that influence an inflammatory cascade. It's important to note that low neutrophils, which is called neutropenia, increases a risk of infection. And then finally, on this particular slide are eosinophils, which are another type of white blood cell that has a role in destroying parasites that are in the body. Two other cells of natural immunity relate to basophils and mast cells. And while we don't know the exact mechanisms of these cells with respect to immunity, we do know that these cells are responsible for the allergic reaction we commonly see with disease, and primarily because these cells release histamine, which cause an increase of blood flow to the affected tissue. Previously, we defined pathogens as any microorganisms that have the capacity to cause disease. On this particular slide, we'll discuss the differences between principal and opportunistic pathogens. In principle, pathogens really relate to those that are able to cause disease in an intact host. These are typically bacteria that invade parts of the body that normally are free of germs. An example of this would be pneumococcus, which can be responsible for diseases like pneumonia, meningitis, and middle ear infections in young children. And if these disorders aren't treated appropriately, these could lead to sepsis. Opportunistic infections are a little bit different. These are pathogens that require some type of deficiency in the host to cause disease. And two examples here are Pseudomonas and Pneumocystis. And Pseudomonas is commonly seen in neutropenic patients. And remember, these are individuals who have a low neutrophil count, which, as we mentioned, also increases the risk of infection. And Pneumocystis, we commonly see this in individuals who are HIV positive, and it's a primary cause of pneumonia in that particular patient population. So now that we've described pathogens, let's describe some of the defenses that the body has. And this slide lists off our first line of defense against pathogens. First and foremost is really the skin, as intact skin is really going to be the best defense to any pathogens. The mucous membranes, which line the mouth, nose, eyelids, and trachea, are also extremely important. The mucous membranes have secretions that have antimicrobial properties, which are very effective at fighting pathogens. The respiratory tract, of course, we know about simple coughing as a means to expel foreign bodies and pathogens, but also the mucociliary epithelium, which transports pathogens away from the lungs. It's important to note that cigarette smoking destroys that mucociliary epithelium, which makes smokers a little bit more at risk for some of these pathogens. The intestinal tract has a pH that's a bit more acidic, which helps fight disease. Also, the pancreatic enzymes and bile both have antibacterial properties associated with them. And then finally, for the genitourinary tract, we spoke about this a little bit in our GI-GU lecture, but we know that acute cystitis or urinary tract infections are more prevalent in women than men. One of the reasons is that the urethra in women is only about 4 centimeters compared to about 20 centimeters in men. And all this means is that the bacteria has a shorter distance to travel. To combat that, women have a more acidic pH, which makes it harder for bacteria to thrive. And once we get past that first line of defense, we have several mechanisms in place that can combat disease. The complement system, which is really a cascade of events that activates antibodies, phagocytic cells, and cytokines, which, as we've spoken about previously, are really signaling cells that really can bring on this inflammatory process and cascade, are all very, very important in attacking pathogens. And you'd ask, well, how would disease potentially be spread? What's the chain of transmission? We outline that a bit on this slide. And so first off, you have to have an infectious agent as well as a reservoir for that infectious agent to foster growth, multiply, and reproduce. There also needs to be a portal of exit and a mode of transmission for the pathogen as well. This slide provides several examples of the most common portals of exit for pathogens in the body. Contact transmission is the most common way that disease is spread. We look at direct mode and indirect modes of contact. This slide describes direct modes of contact where an infectious agent is transferred to a susceptible host by direct contact from another human being. Take a moment and look at the list and familiarize yourself with these direct modes of transmission before moving forward. The indirect mode of transmission doesn't deal with human contact. Rather, it's contact through another vehicle, object, or organism. In this particular case, we could see organisms being transferred through tick bites, mosquito bites, food, or soil. Again, this indirect mode of transmission doesn't deal with human-to-human contact, rather it deals with contact through some other vehicle. This slide describes the mode of entry for pathogens into the body, including ingestion, inhalation, percutaneous injection, transplacental, and mucous membrane transmission. And once inside the body, regardless of how it got there are several factors that will influence whether or not a pathogen can turn into an infectious disease. These relate to general health status and the body's defenses and immune reactions. Note that diseases like diabetes, renal failure, and pulmonary disease will certainly influence our body's defenses and reactions, as well as normal aging process. As we know, older individuals are more susceptible to disease than younger individuals. It's important for us to take a moment and discuss nosocomial infections, which are defined as infections that are acquired while a patient is hospitalized. And in the United States, about 5% of individuals who enter the hospital without an infection actually acquire a nosocomial infection. There are some risk factors for individuals to develop these types of infections, including the use of indwelling catheters, IV usage, and surgical wounds. And so in these individuals who have these invasive techniques and procedures, when they're at higher risk for nosocomial infections, we want to be particularly cautious about the prevention of these type of infections in these individuals. Let's talk for a moment about Staphylococcus aureus, or Staph A bacteria as it's called. This is the leading cause of nosocomial infections in this country. And Staph A is a bacteria that we commonly see residing on the skin, and it can be passed through person-to-person contact. However, Staph A cannot invade through intact skin. However, if there is a breach in the skin, we could potentially see skin infections associated with this, which may lead to pain in the area, redness, rashes, or even blisters or boils. We could potentially see Staph A with respect to food poisoning. In that case, we would see gastrointestinal symptoms related to abdominal pain, diarrhea, nausea, and potentially vomiting. And if it becomes bad enough, we could potentially see sepsis, where we now have an infection in the bloodstream, and we could potentially see, in these cases, systemic illness, symptoms associated with systemic illness like chills or fever. The bottom line here is that this is a relatively common bacteria, and it does cause up to 80,000 deaths per year with respect to infection. So a staph infection is commonly treated with antibiotics. In this country, we've seen an interesting phenomena where Staphylococcus aureus is actually resistant to the two most common antibiotics that are used to treat this, namely vancomycin and methicillin. We've seen these resistances in part due the conventional thinking is that perhaps these antibiotics have been used too much and now these bacteria are resistant to them. Either way, these are important considerations, especially for those of us that are going to be working in hospitals. With respect to vancomycin resistant Staph A, in that particular case, once again, we could see skin lesions associated with this particular type of infection, including cellulitis that would lead to red, swollen, painful, warm skin. And if it's systemic, we could potentially see a fever as well. With respect to methicillin-resistant Staphylococcus aureus, or MRSA, We could potentially see healthcare associated MRSA. In this case, individuals who've been recently hospitalized or potentially on dialysis or in a nursing home could potentially be at risk for that particular type of disorder. And then community associated MRSA, we sometimes see this in individuals who are in close quarters with a lot of direct contact. So we could potentially see athletes at risk for MRSA infections, young children, and potentially the military individuals who once again are in close quarters. The image on the bottom right shows a cutaneous skin lesion, an abscess associated with the MRSA infection, and the graphic on the left shows the different areas of the country and their rates of methicillin-resistant Staph aureus. And you can see in the small graph in the bottom left-hand corner of that image, it shows the incidence of MRSA, and it shows how it's increasing over time. And this is a concern that many healthcare organizations continue to deal with on a daily basis. This slide shows the increased frequency that we see in MRSA infections from 1993 to 2005. Note the increased frequency that we see in this particular type of disorder. With respect to the signs and symptoms of infection, there are really many that are associated with this, and depends upon the particular system that's affected as to how these symptoms are going to manifest. So for example, if we're dealing with lesions in the skin, we're likely going to see redness, pain, rashes, and potentially blisters or boils associated with that. If we're dealing with infections that deal with the gastrointestinal system, we're going to again see abdominal pain, but we also see diarrhea, nausea, and vomiting. And then if we're dealing with systemic infections that have affected the blood, we potentially see things like fevers and chills, sweats, malaise, nausea that could potentially lead to vomiting. And then if we're dealing with individuals who are older, changes in mentation, that's a common method of the initial common way that these infections may manifest, especially early on in the course of a disorder. And then of course, from a physical exam perspective, we would see enlarged lymph nodes as the body tries to fight this particular disorder. If an infection has become systemic, it's common for the individual to develop a fever. And all that is a sustained body temperature above the normal reading of 98.6. Some conditions will not produce a fever over 102, while others consistently do. And so anything over 104 can cause delirium or convulsions, so these are medical emergencies. It is also important to note that, especially in those conditions that may not produce symptoms over 102, the patient still may feel sick with this, so they may still be experiencing things like fatigue and malaise. They may have body aches and chills, and in those particular cases, it is important to go ahead and take a fever, because we commonly will see a fever with malaise as well. And so fever, very, very common sign of an infection, and something that we should be on the lookout for in our patients. And anything over 104 would be a medical emergency. As I mentioned before, fever is a very, very common sign of an infection. But with a fever, there's also a long list of conditions that are in the differential for this, including neoplasms, dehydration, brain tumors, inflammation that could even be potentially autoimmune in nature, especially if we're thinking about things like rheumatoid arthritis or lupus. Certain medications could potentially cause a fever, as we mentioned, infections for sure, and even MI. MI commonly may cause sweats, and we may actually see a slight fever as well while someone's in the midst of that particular disorder. Let's take a moment and discuss some of the signs and symptoms that may be seen with infection. If we're dealing with skin lesions, we could see inflammation and exudates. The inflammation may be characterized by rash or potentially red streaks. If you look at the image on the right-hand side of the screen, bottom right hand side of the screen, you'll see a characteristic image of cellulitis. The top image would be a more acute image, while the bottom image would be related to treatment. After a period of time, we would see the lesion becoming less inflamed and smaller. But if you look at that lesion, there's likely a breach in the skin, and we commonly see these lesions moving up and radiating away from the infection site. And this is a common condition that we see, or common image that we typically see with cellulitis. We may also see inflamed lymph nodes, and if we're dealing with joints potentially being infected, we would see joint effusion as well as pain associated with those type of disorders. With respect to diagnosis of infection, there are several stages that we would like to employ. The first being direct visualization of the organism and detection of the microbial antigen. We'd also want to ensure that the organism is isolated in culture, and we're going to search for clues produced by the host immune response to specific microorganisms, as well as detection of specific microbial nucleotide sequences. All of these are going to be important to determine the particular pharmaceutical that might be employed to help defeat the infection. This concludes our talk on infectious diseases for PT 549.